Blood transfusion for gastrointestinal bleeding. Acute gastrointestinal bleeding is a common emergency condition associated with high morbidity and mortality. It is a frequent indication for red cell transfusion because acute blood loss can decrease tissue perfusion and the delivery of oxygen to tissues. Transfusions may be life-saving in patients with massive exsanguinating bleeding.
This video is about upper GI bleeding. Upper GI tract. This includes your esophagus or swallowing tube, stomach, and part of the small intestine. The causes. Sometimes even with testing, the cause of bleeding is not found. Most commonly ulcer. This is when the mucous members of the GI tract break down. Stomach acid wears through the membranes, then it can bleed. Also enlarged blood vessels. These are called varices. People with liver problems can get high pressures in the blood vessels of the esophagus. When these vessels enlarge, they can sometimes bleed. Injury to the GI tract. Sometimes forceful vomiting can tear the lining of the esophagus. This can lead to bleeding. Symptoms. Symptoms of upper GI bleeding include vomiting blood. Sometimes GI bleeding starts with vomiting bright red blood. Bleeding can be slow and the blood is partially digested. This will make the stool look like coffee grounds. Or not only the stool, but the vomitus will look dark as well. Black and tarry stools. When blood sits in the stomach or intestine for a while, it gets digested. It turns dark and black in color. Bowel movements can be black with upper GI bleeding. Symptoms of blood loss. Other GI bleeding symptoms are because of blood loss. Your blood pressure may drop very low. You can feel lightheaded or weak. You may even pass out. Your skin and palms may look very pale. The inside of your mouth, under the tongue, and inside the lips may also look very pale. GI bleeding is a very serious problem and can be life-threatening. During your visit today, you were placed under observation. You had special tests done. These may include blood tests, x-rays, scans, even endoscopy. Endoscopy is when the GI specialist puts a tiny camera down through your throat. This is to look at your esophagus, stomach, and small intestine. This is to find the area of the bleeding. When found, some areas of minor bleeding can be fixed. Medications. You should use medicine called a proton pump inhibitor, PPI. These medicines include Prilosec, Prevacid, Nexium, Protonix, and others. Use them as directed. You should avoid soda, chocolate, mints, citrus juices, smoking, alcohol, and spicy foods. You should seek emergency medical attention if you're experiencing more bleeding, abdominal pain, you vomit repetitively, or vomit blood or material that looks coffee grounds, you get fevers or shaking chills, you get lightheaded or faint, or you start getting short of breath. You must follow up with your primary care physician. We might need to repeat a blood count to make sure you're not losing blood slowly. Also, check your liver enzyme coagulations and find the underlying reasons for your bleeding. For more videos like this video, please
Research. Controlled trials have shown that for critical patients, a restricted transfusion strategy is at least as effective as a liberal strategy, while substantially reducing the use of blood supplies. However, these studies excluded patients with gastrointestinal bleeding. Furthermore, studies in animals suggest that transfusion can be particularly harmful in patients with bleeding from portal hypertensive sources, since restitution of blood volume after hemorrhage can lead to a rebound increase in portal pressure, which is associated with a risk of rebleeding. Results: the restrictive strategy resulted in lower rates of additional bleeding, shorter hospital stays, fewer rescue therapies and adverse events, and 60% fewer transfusions than the liberal strategy.
Mortality following blood transfusion for non-variceal upper gastrointestinal bleeding by Dr. Taha and colleagues, University of Glasgow and Crosshouse Hospital, Kilmarnock, Scotland, United Kingdom. The wisdom and safety of blood transfusion are being questioned in mild and moderate cases of upper gastrointestinal bleeding in light of falling donor numbers and the high morbidity and mortality observed in patients treated in intensive therapeutic units after trauma and after surgery. We therefore aim to measure mortality following blood transfusion for non-variceal bleeding at 30 days and 2 years over a 6-year period. Adult patients were included if they had non-variceal bleeding and regardless of their comorbidity or the cause of their bleeding. They were excluded if they had esophageal or gastric varices, portal hypertensive gastropathy, or if they were endoscoped but were well enough not to require hospital admission. Patients' assessments included the following: hemoglobin and other routine blood tests, endoscopy, comorbidity using Charlson's score, the complete Ruckle score for upper gastrointestinal bleeding, the need for blood transfusion, and death of any cause. 1,776 patients presented with upper gastrointestinal bleeding, of whom the following were excluded: 90 with varices, 341 who were not admitted, and 5 who had incomplete data. The remaining 1,340 patients with non-variceal bleeding were analyzed, and 42% of these were transfused. The overall mortality, regardless of transfusion, was 5.3% within 30 days and 25.8% within 2 years. As for demography, patients who were transfused were significantly older and had higher comorbidity scores than those who were not transfused. Also, the transfused patients had higher Ruckle scores and lower hemoglobin levels. The overall cumulative mortality was significantly higher in the transfused patients over the 24-month period of observation following upper gastrointestinal bleeding. When patients were subgrouped according to their baseline hemoglobin level, the 30-day mortality was higher in those transfused having had a hemoglobin level greater than 10 gram per deciliter. Similarly, the 2-year mortality was higher in patients transfused when their hemoglobin level was greater than 8 or 10 gram per deciliter. The hazards ratio for 30-day mortality following blood transfusion was still higher even after adjustment for Ruckle score, hemoglobin, age, and Charlson comorbidity score. The same applies to the hazards ratio for the 2-year mortality following blood transfusion. In conclusion, mortality is higher following blood transfusion for non-variceal upper gastrointestinal bleeding. Alternatively, the need for transfusion might predict mortality following non-variceal bleeding. The take-home message from our observations is that the need for blood transfusion should be reviewed in less severe cases of non-variceal upper gastrointestinal bleeding. Also, blood transfusion should be avoided or deferred if the hemoglobin level is greater than 8 gram per deciliter, and particularly if the hemoglobin level is greater than 10 gram per deciliter. Thank you for your interest in our work.